got my cup of tea here.
I've got my tea.
Jason, what tea have you got? What have you picked?
I'm a strong, so I've got Clipper at the moment, organic, and it's a strong everyday tea. It's very important. I'm a bit of a connoisseur in tea.
Are you?
Twinings or Clipper. That's the only one I go for.
As a northerner, it's got to be a strong cup of tea. And at the moment, you know, I'm in the south.
Milking first.
No, not milking first. Oh no, milking last. Milking last. Proper northern way. But I'm surrounded by southerners who drink their tea really weak, and I just can't. No. Every time I look at it, I'm slightly offended.
Yeah, no, I know what you mean. I'm a bit picky about my tea. I put the milk in first though, because otherwise you get that scaly stuff on top. Yeah.
Oh, milk in first.
And you get a decent colour. I can't tip this enough for you to appreciate the colour of it, but it's a proper strong cup of tea.
I'll just believe you. I'll take your word for it. I would approve. Okay, cool. All right. Well, welcome to this episode of Cancast.
Thank you.
Today, I've got the absolutely fabulous Chief Inspector, Jason Kew from Thames Valley, who I've mithered a little bit over the course of setting up Cancard, and he's just absolutely brilliant. So it's amazing to have you here, Jason. Thank you so much for having a cup of tea with me.
It's my pleasure, but I'm hardly fabulous. I have to say that. I'm just get along.
I think I completely disagree, because I've had to spend more time on the phone with police than I've ever done in my life. And obviously I've spoken to loads of forces of different people in different areas. And as soon as your name comes up, it's like you're some kind of harm reduction rock star. Everybody knows about you. And I passed on an email actually the other day, about a guy who was just so enthusiastic. I think he must be starting a Jason.
That's lovely. That's lovely to hear. And but I think the reality is actually that those in policing have been less confident perhaps to talk more about harm reduction. I think that's the issue, is that, you know, I think, and I hope this changes, because what I talk about is not anything new. It's not anything radical. It's evidenced, you know, it's perfectly legal, safe, you know, and in fact the College of Policing, you know, recommend the majority of what I talk about, you know, so it's not mainstream. And I think when you get someone, I guess, like me at the moment talking about this, I'm a unique voice, I think, and I think that's why people then think, oh yeah, Jason Kew talks about that, and actually it should be more mainstream. You know, everyone should be talking about it, because you know, drug use is wide throughout society. It's not just a unique thing for a certain number of people. It's, you know, it's much wider, and actually, you know, we've got an important role to play in reducing harm, education, you know, and helping people recover where necessary, but keeping people safe is the main thing. I could go on all day about that. I'm very passionate.
No, absolutely. And I think it just takes, within an institution, and this is any institution, we could be talking about the NHS or universities or whatever, it does take a voice to step up and start talking about this. And I guess that's what you've been, you know, you're known for within the police, is actually saying it out loud. And I think that's clearly made a huge impact. And you know, you're very well known within that space, and possibly, I don't know, I mean, there are a lot of people that know your work, but maybe you could tell us a little bit about what you do for those patients who maybe don't know about what you do. That'd be ace.
Yeah, cool. Okay, so so I'm a chief inspector. I work with the Violence Reduction Unit, Thames Valley. So that's not just a police partnership, that's multi-agency, so charities, schools, you know, business sector, health, but basically it's aiming to, you know, make a whole system change, or bring a whole system approach to reducing serious violence. And drugs is just one element of that. It's not the the sole cause, it's just one part of that process. So my job specifically is drugs exploitation and harm reduction, and I am a drugs lead for Thames Valley, but I work on schemes such as drug diversion. So that's where we will find a young person in possession of any controlled substance, regardless of their previous, history, whether that's offending or otherwise. And what we do is turn what would have been previously an incriminating encounter into a positive health one by diverting that person to an assessment about what they've been found with, but also what their peer group are using. Or, it might not be the cannabis that they've been found with, it might be the ketamine that they use at the weekend. And then they're afforded tailored education about that without receiving a criminal outcome. So they haven't got a criminal footprint, and that's huge. We can't have 15, 16-year-olds at the cusp of their future, that being destroyed through what is a health matter. So for adults, we have a similar scheme using a deferred summons approach. So and we've got 88% of young people voluntarily completing the whole course, which is massive. It shows the uptake. And then for adults, we've got high 90s. So that again, it's just proving that people really want and appreciate quality education. So it's really key. I think some of the other aspects of serious violence is working on schemes such as heroin assisted treatment. So that's where the most, using an analogy, using evidence based from elsewhere, the top 10% heaviest heroin using groups consume the most. I think everyone would appreciate that. And if you were to re-engage these people who were using problematically, who are disengaged, it's evidence that they're consuming 30 to 66% of all the illicit heroin. That's quite a significant chunk used by quite a small number of people. And these are people that methadone doesn't work, buprenorphine doesn't work, so traditional treatment or opiate substitutes don't work anymore. But by prescribing diamorphine, which is closely resembles illicit heroin, you can re-engage that person to the drug that they need. And it's actually reducing harm, reduces crime significantly, reduces the need for that person to go back into the criminal the criminal networks, if that makes sense, to go and buy, to go and perhaps steal in order to buy. So there's many different outcomes, but the main ones are that person's safe. They're back in, obtaining, a medically prescribed heroin rather than, illicit street heroin from probably a harmful drug dealer, and not knowing exactly what it is, but obviously entering all the exploitation links that might take with it. And then, advocating supervised injection facilities, so safe spaces where someone who needs to safely inject, who might have open wounds, who can receive wound care, sexual health, even clothing, even housing, an epicenter of support. And I think these safe spaces are really crucial. So there's lots of things we're working on, and they're quite wide. But most importantly, it's about reducing stigma, reducing eliminating judgment about many different people use drugs for many different reasons. Some for pain relief, like we're talking about, medical cannabis, but also heroin is actually a pain reliever. Some heroin users I've seen over the years have used since their early teens to numb the pain of trauma, numb the pain of what's going on in their childhoods. And that's, and heroin's the only thing that kind of like holds that pain away. And I think that's, we need to look underneath.
Yeah, absolutely. I mean, to me, it just sounds like the most common sense approach. And I think that the gateway to problematic drugs, the majority of the time is trauma, isn't it? Mm. And instead of actually wrapping an arm around somebody and saying, how can we help? I think the worst thing we can do is limit their life choices by then giving them a criminal record and putting them in facilities where drugs are even easier to obtain. And I think that's why, I personally think that this is the way forward. And I really hope we start to see your work and the work of other forces in this area start to spread throughout the UK, and for it to become the norm, because I think there's we've got a lot of work to do around this.
Everything I said there wasn't controversial, was it? It's not controversial.
No, not remotely.
I mean, why would you? And this is the point about why more police officers, police forces talking in this whole system approach. You know, nothing there is controversial. It's all about saving life, reducing risk, and reducing harm. That's everything that we want. You know, why would society want to send someone who lives on cardboard, who's problematically using spice, because spice is the only thing that person, the only drug that person can get hold of, because of cost, and it causes such devastation to their bodies. You know, why would you want to put that person in a police cell? You don't. Why would you do that? You don't. That's the last place they need to be. It's actually the safest place for them to be is with someone who understands them, who wants to look at the trauma underneath that use, and then look at making that use safer, and then actually wrapping, you know, a blanket of support around that person to get better, to make some, you know, healthier choices perhaps, or to, you know, to deal with the trauma. And, you know, you're not going to tackle addiction unless you look at the reasons why that's occurred.
Yeah. And I can totally empathize with the, so I was on fentanyl for years, which is stronger than street heroin, but, you know, we take it in a lower dose, and that was for pain relief, really. But I wasn't using that for trauma. I was using that for pain. But the withdrawals, my God, it's exactly like Train Spotting, but more boring.
And if your GP then said, because if that was prescribed and your GP then took that away overnight, and you've developed dependency, where would you go? Where would you naturally be forced to go to get that substance or an equivalent?
Absolutely.
It's either online illicitly or going out to buy it, isn't it? For, you know, so routes to drug use is, you know, it's so wide across society, and there'll be, you know, hundreds of people in your situation who've never traditionally thought that they were, you know, acting illegally or acting criminally, but they're forced to go out and buy it illicitly. And it's the same analogy as the medical cannabis. You know, people have found a substance that they can, you know, it reduces their pain, but actually now, you know, they can't obtain that legally. There's an inequality there that's, you know, another big issue. So.
I think we're going to see more of that, actually, Jason, because the newest NICE guidelines on chronic pain, they've actually withdrawn support for opioid medication for people with chronic pain. And we've got millions of people in this country who are using, you know, sort of low, sort of, you know, like your minor opiates, all the way through to your morphines and your fentanyls for pain. And that is about to be taken away from them. And my concern is that the only thing that they're recommending instead is acupuncture, which I think is great, but I think that there's going to be a massive increase in people who don't really realise that they've got a physical dependency. I certainly didn't until I started withdrawing. Then I was like, oh wow, this is some major stuff. Yeah. But my concern is that, you know, personally, obviously from my experience, I can see medical cannabis slotting in there quite nicely as a replacement, a much safer replacement. But because we don't have that access, I'm concerned about people turning to, you know, to harder, you know, sort of dirtier versions of those opiates, which is going to be problematic if it's not handled properly. So there is some concerns that you know that could happen. So I'm really glad that schemes like the ones that you're involved in and others are up and running, because I'd hate to see anybody who is in my quite desperate situation then be criminalised because they're seeking something that they've become physically dependent.
Yeah, no police officer wants to see a patient in pain, you know, in a police cell. You know, that's not what affecting the law is about. It's about, you know, ensuring people get the help they need. And I think diversion is so crucial. You know, obviously I'm a huge advocate of diversion, having created a scheme, but I think, you know, we truly need to, you know, optimize diversion. I think, you know, there are so many examples like you've just described about, you know, people seek, you know, help. I mean, just coming back to that example you used, but where does someone in your situation, and there'll be thousands of others, reach out for that educational support? When does, you know, you can't, to use a great phrase from an author of the recovery handbook. Emma says in there, how do you recover from a condition you don't know you have? That's huge. That's absolutely true, isn't it? Some people will be using pain relief and then they develop a dependency but don't realize that, and then where do you turn to? You don't turn to your GP, because if you've got kids, you fear that people are going to be, your kids could be taken into care or safeguarding or social services involved. That punitive response, we need a much more carefully considered approach for people to seek help when they need it. That's absolutely crucial. Absolutely.
So turning back to medical cannabis, when I first called you about Cancard, I don't know, it was way over a year ago now, and I was really excited by your response, because I thought, okay, so the godfather of harm reduction thinks this is a good idea.
Easy.
So I was, and obviously there was a lot of police input, but what did you like about the idea in it? As we started working on it, what do you think? How do you think it could be helpful?
I think from the outset, it's about informing my colleagues about what cannabis, medicinal cannabis is about, but what cannabis is about. So there'll be many of my colleagues, myself included, before I learned much more about drug policy or drugs, they just do not know. They find someone with cannabis, they won't know about the reasons for that use. The majority might be recreation. It might be, but actually, recognizing that some people will be in pain, able to obtain it lawfully medically, that's absolutely that will be missing from their kind of mindset, if that makes sense. So the card, what it will bring is that opportunity for a cop on the street to firstly recognize, this is something a little bit deeper than just possessing cannabis. This person's actually in pain, they're a patient, they're medically legitimately, lawfully able to obtain it. However, due to an issue, and I can't go into this out of respect for commissioning NHS and everything else, they're not able to obtain that cannabis through no fault of their own, then that's the reason they're in possession. And I think what the card will do is enable that either discretion excuse me, or decision making, or help the decision making about the outcome of that possession incident. And that could be diversion, like Thames Valley scheme, West Midlands have got a scheme, Durham have got checkpoint scheme, different forces have got different diversion schemes. And actually the best way for that person found in possession is to go through a scheme and not be criminalized, if that makes sense. So that's really crucial, isn't it? But also it might be that there's some other issues around that person's use that might need to be looked in a bit deeper, like some forms of safeguarding or support, or it could be an opportunity to get some other help that wasn't so obvious or visible in that person's life. Basically, it's taking a trauma-informed look at that possession. It's not just about someone being found with cannabis and being prosecuted in the usual ways. It's a little bit deeper than that.
Yeah, absolutely.
So that was a bit long-winded.
No, that's excellent. It's been really good, sort of touching base with different police forces and hearing about what they've got going on, but also about the sort of general sort of public sort of lack of knowledge around the fact that these things are available from clinics now. And I think even that has been an eye-opener, and the training that we've been doing, a lot of forces have reached out for a few of them have been, like PSEM does a blank card so we can use it in the training. I've done some video training with some, and it's been amazing. And I think that actually what we're starting to see now is, now people have got their cards, is that actually a community that used to look over their shoulder and fear the police, and have done for many, many years, are now actually engaging with them in a really positive way. And the training has been quite successful in that, every patient who's seen a police officer has had a chat with them about it, has known about it. We haven't had any force come back saying, oh, we don't know about this. The police have embraced it as a tool. And I think now what we're starting to see is those relationships that were fractured from a really vulnerable community start to be repaired. And that, I think, that's amazing. That's like my favourite thing about this. Because those people, obviously, if they were victims of a crime, if their car got nicked, or they would have to engage with the police. And I felt very, very sad that community was at war, essentially. Not at war, but there was an issue in the communication between the two. So I'm just really hoping that continues, because I do think that those relationships could be rebuilt and reestablished within communities.
Yeah, I think it's it's taking that trauma-informed look, isn't it, about drug use. I think it's reframing drugs as not just cannabis, but reframing drug use in a trauma-informed way. You've got to differentiate between problematic use in where someone is desperately in need of help in some form, or people who use drugs and do not require any help at all. It's looking at that trauma-informed need. And I think there'll be many people who use drugs who don't need any kind of state intervention at all, who will not feel it. But I think there's a duty, but it's a two-way street. So the card will enable the community who use, they'll be able to recognize actually the statutory, the state, if that makes sense, has a duty, it's like cigarettes. We have a duty to put on there that smoking can kill, because it does kill. It's the evidence. And actually with other substances, I'm not centering cannabis here, but we have a duty to reduce harm where we can. That's the job of the state, isn't it? That's what the public trust us to do. And that's what the public ask us to do. So if we can, be agents of that harm reduction, then that's our evolving role. And I think it's a two-way conversation. It's with users have to recognize and appreciate that's what we're trying to do. Then that's the whole aim of diversion, is to enable someone to have an assessment about what they're using. They can make an informed decision then about how much they're using, whether they need to reduce or what, and then they receive education about that. And I think it's what we want to do. What we want to help people do is to stay safe. That's it. Without normalizing or acquiescing drug use. We can't condone drug use, clearly, but we recognize that drug use is so wide throughout society. We need to do something a little bit different about that to reduce potential harm.
Yeah, absolutely. And I still think there is some, the card, my work doesn't really solve, we're not really solving a massive issue. I think the issues mostly at the moment are that, there's a few sort of lockdown issues with access and vulnerable people having to go out and visit their florists, getting cars with people who've been to see 12 people before. There's a lot of that happening, but there's also, I suppose it's just not, with the law as it stands, it's not ideal that a patient, we have some patients accessing very safely, but we also have some people who are very poorly. There's a lady with MS who always springs to mind, who's in a wheelchair, and she has to wheel herself down to the local park at night time to meet a dealer in an unlit car park. And I just think, I can't, and I've been there myself, and I just, I can't really stand by that as an ideal way of accessing something which actually helps her get out of bed and back.
That story is really powerful, isn't it? Then, because we can talk about that now, because many people won't necessarily realise actually that the first question that people might say to that is, well, why isn't that MS patient, why isn't she receiving adequate pain relief from her GP? And it's worthy of people then to realise actually that prescribed pain relief doesn't touch or doesn't address what cannabis can provide. And it's that, again, it's that I'm no expert on pain. Obviously I'm not, I'm a copper, I'm not a pharmacist, but I recognize that people are the best judge sometimes of what works for themselves. And and I think it's that it's recognizing that it's recognizing that someone's found cannabis to be more effective than what they're getting from a GP, if that makes sense. So and obviously that's why medical cannabis is now available. And I think it's we've got to follow the evidence, haven't we?
Absolutely. And I'm hoping that with the schemes and stuff we can put into place to protect these people and offer them safer alternatives, I'm still sort of got my head in the game, trying to kind of come up with ways in which we can, you know, use the amazing community that we've built of police officers, of doctors, of MPs to sort of try and support these people better. Because I think we're a way away from, you know, having affordable access. As you know, my prescription costs 1,500 quid for 1 month. It's just like vast majority of people. I mean, I don't know anybody who's got a spare £1,500 a month.
No, well, that's a rent for a house, isn't it? In you know, in London.
A nice house, yeah, absolutely. And so, you know, I'm still working on, my brain's in overtime now about how we can make this better, how we can factor other things in and make things safer. But I suppose you know, I'm hoping that we get to the stage whereby people can access this under medical insight properly and safely, and that, you know, that the police won't need to worry about, you know, medicinal cannabis for much longer. I hope that we get to the stage where people, you know, can grow a couple of plants in their garden if they want to.
What's the situation with the availability of medicinal cannabis then? How many people have you, how many eligible patients do you estimate have you got?
So we know from the YouGov survey that we had around 1.4 million adults saying that they use it for medicinal use. So what I did from that study is I took the raw data and I looked at the conditions that they were reporting, and I compared them to what was being prescribed for in the private clinics. And it turned out that 1.1 million of those had conditions for which were being readily prescribed by the private clinics. So essentially they had an eligible condition that they could, you know, if they had the money, they could walk into a private and get a private prescription tomorrow. And so that's essentially the sort of numbers that we're talking about, who at the moment are only accessing on the illicit market because they can't afford to go that route.
Yeah.
And, you know, those numbers I just think are massive. It's like 2% of the population are consuming successfully already. And, you know, I think we need to, there's lots that can be done, but I do think that we need a more sensible approach to, what I'd like to see is, so we have this community of people that are saying, this is working for me, it's brilliant, it's better than anything I've tried loads of drugs, and this is the best thing for my epilepsy or whatever it is. But I'm having to get it from, you know, Johnny the florist. And I think that the best way to do it is kind of what the Danish model did, which was really cool. So what they did was they said, okay, so if you're consuming cannabis illicitly and you're saying it's working, we'll give you a standardized medical product to use, and you can just report back to us. Is it working? You know, how many seizures is it reducing? That kind of thing. And I thought, wow, that's really common sense, because it keeps the money away from the organised crime. The police don't need to worry. The patients are safe. The medicine arrives on their door every month, and they're contributing towards an evidence base.
Yeah.
So I really like the way they did it.
Yeah. So so in currently then, it's just, I mean, this is just to help people kind of understand, you know, this situation as to what we've got in. So so an average private medicinal cannabis script from you know, a private doctor would be what, 1,500 quid a month?
So mine was 1,500. It's come down a little, but not much. So it depends on the product. We've probably got 5 or 6 strains available, and that's the other thing, is that even people who are quite affluent and can afford a private script often go try out the product and say, you know, these strains don't work for me. Because we've got 4,500 strains of cannabis. And patients have spent 20 years treating their Parkinson's with it or something, and so they're like, okay, I know these strains work really well for me, but actually they're not available. And so we've got another issue on top of that. And and I don't know what the answer is. I don't know if we're ever going to get to the stage where we've got the library of medicines available to suit everybody's needs, but
it's evolving. So even medically, it's an evolving, you know, it's an evolving process, and I guess to what works. Do you know then so how much equivalent would it cost, you know, a patient to illicitly buy that then? So you're thinking, what, 20 quid?
So my private script was 1,500. The same amount would cost me about £170.
Wow.
If I went to my supplier, if I grew my own, it would probably cost about 30.
Wow, that's amazing, isn't it? That's a huge. So you can see why people obviously clearly are drawn to either growing their own or buying it illicitly because of that cost. And
Yeah.
then if and then with the role of cannabis social clubs, because I've heard some quite so dividing the moral bit of my role, police officer, you know, and that. So I've heard some really kind of heartwarming stories actually from cannabis social clubs where a social club would help out a patient who was unable to afford and actually didn't go and buy. Now I'm going to use the word illicitly here because obviously cannabis clubs are illicit, aren't they? You know,
Yeah.
still, but rather than going out on the street to buy from a you know, a dealer, and they obtain the right kind of strain from the cannabis social club because of that level of expertise. And actually, part of me thinks, obviously, I know that's against the law currently, but actually, what a wonderful cooperative that is to enable someone to safely buy what's working for them in a social club. And also, when people are, you know, unable to afford that pain relief for that period of time, they can then obtain it from the social club because it's a cooperative, and it's like, and there's no profit involved. And you think, well, if that model can exist, you know, illegally, what where's where's the harm in that? I can't understand, you know, where in the supply chain is that harm being created, and and I can't see it. So it's in a
Yeah.
regulated, so basically you've got a regulated cannabis market without any profit, but it's serving a community that's in pain. Does that make sense?
Yeah, and you know, and they're doing fabulous things, and they're testing. You know, they're testing to make sure there's nothing
Yeah,
untoward in the substance, and that the patient knows what the levels are and stuff. It's a brilliant setup. At the moment, obviously, it's underground. There's only one exception, which is sort of a tolerated club, which obviously is Teesside, which is on a sat smack bang in the middle of a high street, has been for a while, and you know, the police, you know, have helped set it up because, and just like some of the things you were just saying, they, you know, their ideas is that, you know, this can solve a lot of issues and actually support people in the community, help the
yeah.
community help each other.
You can
uh,
understand it. You
yeah,
can understand it, can't you? Without, you know, I've got a duty not to normalize or acquiesce or, you know, incite or encourage any kind of criminality. But you know, you can see the benefits in that example, can't you? You know, people aren't going out to go and buy from a, you know, a violent county line, for instance. They're going to a reputable, you know, local supply cooperative that, you know, is meeting their needs, but also disengaging them from the criminal market, if that makes, or the wider criminal market.
yeah,
I can see it. I can see it. You know, I think many of my colleagues will too. It's just that both are against the law, aren't they? It's a complicated
yeah, it's really,
fabric of, you know, of cannabis. I think what I was going to say. So talk to me about CBD then. So obviously CBD oils are the big rage at the moment. You see them in Holland and Barrett, and you see CBD everywhere, don't you? As a pain relief and as like a holistic kind of, you know, herbal medicine. But what about what's the role in CBD, like, you know, Holland and Barrett CBD in pain relief for, you know, MS patients?
so
Totally different, I guess.
yeah, I suppose it is. So
I'm
cannabis,
turning the interview around. Did you see
I
what I
know.
did?
I say I've seen what you
I'm
did.
like,
This is a
I'm the copper now.
typical copper, typical copper here. Yeah. So CBD, you know, it's mild. CBD is a great, you know, each cannabinoid, and there's over 100 in each cannabis plant. It's very exciting. I get very excited when I talk about this. So there's THC and CBD we talk about, but there's also, you know, 90 odd others, and they all have different uses. And CBD in the plant is the most anti-inflammatory. It's also, it doesn't breach the blood-brain barrier like THC does, so there's no intoxication, which is why it's become a more acceptable sort of cannabinoid.
Yeah.
So CBD is great. A lot of people with arthritis or mild anxiety use CBD. However, because it doesn't breach the blood-brain barrier and it doesn't bind to the same receptors as THC does, there's two types of cannabis receptors. One of them will accept CBD and the other will accept the other cannabinoids. So THC really is the painkiller of the plant and the central nervous system moderator. And we know most about THC and CBD, but THC, particularly for people with neuropathic issues, can calm down the central nervous system. So I've got a crazy tremor, but apparently you can't see it really, but usually it'd be like this. So that's because the THC has stabilized my central nervous system. Whereas if I just use CBD, I'd still be like this. I'd be like less inflamed in my body. So what's happening at the moment with CBD, unfortunately, is so in Holland and Barrett, if you went into Holland and Barrett today and you picked up a bottle of CBD, there would be a really, really minor trace of THC in there. It'd be really minimal, not enough to cause any intoxication, but it is enough to help the rest of the cannabinoids within that oil work, because there's something called the entourage effect. Now, scientists have named it the entourage effect because what it means is rather than isolating each cannabinoid off, when you consume them all together, they help each other work. So that really tiny drop of THC, which isn't going to affect you or intoxicate you in any way, boosts the effectivity of the CBD, which is really cool. Unfortunately, there's been some changes in the Home Office and Trading Standards. Now they're saying that there can't be any trace of THC in CBD oil. So all we're allowed to have now is either isolated CBD, which is just CBD on its own, or broad spectrum CBD, which is all of the cannabinoids, but they've chemically stripped out the THC. And what we've seen when they've done this in other countries is that patients who were successfully using CBD, full spectrum, with a bit of THC in, doing really well. As soon as that little bit of THC is stripped out, it tanks, and it's less effective. And unfortunately, that's what we're going to start to see happen now. So the likes of Holland and Barrett, in a couple of weeks' time, they'll be selling a different product with the trace THC stripped back.
Yeah.
And that's I think that's going to cause some patients some issues. We know that a lot of the pediatric epilepsy cases, the parents are buying really great quality oils online that have very, very, very tiny trace of THC, which is really working for them.
Yeah.
We also know that they've tried the likes of CBD isolate and it hasn't worked. So there's going to be, I think there's going to be more to talk about when we start to see the changes in that legislation actually playing out in the community. And I hope that brings a greater awareness of what we can do when we use the plant as a whole.
Yeah, I think there's a lot of emerging research, isn't there, around cannabis? I think it is promising. It really is, definitely. I mean, ultimately, what we want to try and prevent is people who need the cannabis for pain relief, and it successfully works for them. We want to avoid them going into the criminal market at all. That's ultimately why we're here. That's ultimately what brought us together, because we have that shared outcome. And I think certainly Cancard will help that. Yeah,
absolutely. Okay, I've got one more question. It's a bit of a weird one. So I've been ending my interviews with this because I think it's a really cool. Somebody asked me this question and I hated it at first, but then I had to think about it and I quite like it now. So somebody asked me if you could wave a magic wand and like completely clear it and have cannabis as you want it, what would it look like? And so I said I would like patients to be able to access it with clinical oversight, those people that want that. I'd like people to feel empowered to grow their own in a safe way. And I'd like to be able to, and this touches on one of our last points, those experts and those community members who've been supporting other patients and really, really know their stuff would be considered specialists in other countries. They'd be on hundreds of £1,000s a year. They'd be like scientists, but at the moment they're criminals. And I'd like to be able to see them spread their wings and share their knowledge, and that's kind of sums it up for me. So what would you do with your magic wand, Jason?
Yeah, well, just for cannabis, I think well, actually, I'll talk about other drugs as well. I think we have a form of regulated heroin already with heroin-assisted treatment and prescribed diamorphine, and I think that there's some really strong lessons there about how to manage, certainly a pathway to a regulated market. I think really for me, the magic wand would be to probably regulate heroin in a similar way quite quickly, even before we talk about cannabis, actually. So because that's driving the huge demand in, organized crime and exploitation and everything else. So so I would start with that point first. However, I know there are complexities with a regulated market and where to prescribe and so on and so on. So I think the heroin assisted treatment model is a strong one to start with. For cannabis, again, a regulated cannabis market is, in my opinion, the way to go. I think that comes alongside forms of decriminalisation, but within probably a framework of diversion. So that links into obviously still having that state-based responsibility, that duty to reduce harm. So we've still got that kind of oversight, but without incriminating people, is rather than by supporting people. I think a regulated cannabis market, though, there's some caveats with this, because I've seen what the Canadian model has brought, and so if you regulate a market, there will be a spike in violence to control the illicit market, and I think we can't gloss over that. There will be some form of competition to control the illicit bit, and the illicit market will be to either provide super high strength or to supply young people who can't go in and buy it from a shop. So you're still going to have an illicit market, and I think that's the area of concern. So I think the regulated supply from pharmacies, and it has to be a non-profit model. You can't have industry driving this, otherwise that creates far more competitive issues about high strength and costs and so on, and also drive inequality. It would have to be a non-profit model, a health-based model, in order to ultimately reduce the risks of high strength THC, because there is some evidence around high THC and mental health, especially with growing minds. So with that in mind, because this is really complicated stuff, and it's it's trying to manipulate the illicit market, where we know that young people will continue to buy, in order that market then is probably so flush with lower strength or less harmful, less high THC content. And I know that's probably aspirational, but I think any regulated model needs to be not for profit, in order to reduce the risk to young people, so that if anything is in the illicit hands, it's lower strength, and is full of wraparound support and education. Because
I love it.
Oh, good, that's good. But I think we can't be driven by profit here. This is a very health is not about profit. We know that there are models out there that are, but you can't have profit securing demand, otherwise you're just replicating an illicit market in a different way.
Fabulous. Jason Kew for Prime Minister.
Don't do politics.
Well, thank you so much. I'm going to stop recording now, Jason, but thank you so much for your time.
Take care. God bless.
Right.
See you soon.
Bye.
Bye bye.